Thank you very much, Mr. Chairperson. Ladies and gentlemen, good morning. It is my great honor to have an opportunity to be a speaker of a plenary lecture. The assigned title to me was, What did we learn regarding AF ablation in the last 10 years? But frankly speaking, I still have more questions than answers for this issue. So I would like to review my story regarding the AF catheter ablation in the last 10 years. Disclosure information. The first one I learned during the last 10 years is now we see the clear clinical benefit of AF catheter ablation. Although Cabana trial failed to prove the mortality benefit of AF catheter ablation in ITT analysis, AF ablation is superior to medical therapy in terms of mortality and cardiovascular hospitalization. And this superiority of catheter ablation was even more significant in the per protocol analysis. In the sicker patient group of HFrEF, heart failure with reduced ejection fraction less than 35%, catheter ablation is clearly superior to medical therapy in terms of mortality, and CASTLE AF trial proved over 40% reduction of overall mortality by AF catheter ablation in patients with heart failure and atrial fibrillation. What about heart failure with preserved ejection fraction? We compared the recently developed H2 HFpEF score before and 1 year after the AF ablation, and the reduction of HFpEF score by AF catheter ablation was more significant in patients with baseline high HFpEF score. And increase of HFpEF score is associated with failed atrial fibrillation rhythm control or sustaining AF after catheter ablation. So baseline HFpEF is good for good responder to AF catheter ablation. Recently, we compared over 16,000 patients who underwent AF ablation with over 92,000 medical therapy group or non-AF population. During over 5 years of follow-up period, the risk of ischemic stroke was significantly lower in AF ablation group than in medical therapy group, and the degree of risk reduction was comparable with the non-AF population. Another interesting finding of this study was AF ablation also reduced the risk of intracranial hemorrhages significantly compared with medical therapy. AF also improved the cognitive function 1 year after the procedure. In this study, MOCA score improved significantly in ablation group, but worsened in the medical therapy group after 1 year. However, the benefit of AF ablation disappeared in patients who recurred as sustaining atrial fibrillation. This is Korean National Health Insurance data, and AF catheter ablation reduced the risk of vascular dementia and Alzheimer in over 194,000 patients without ischemic stroke. Therefore, not only risk reduction of ischemic stroke, but also hemodynamic improvement by restoring sinus rhythm plays an important role in preventing dementia. In this study, we proved the AF ablation also improved the renal function 5 years after the procedure, and also can be done by improved cardiac output after catheter ablation. The second thing we learned during the last 10 years is AF is not a curable disease, but a progressive disease. This is Kaplan-Meier curve for AF recurrence after catheter ablation in my institute. And over 4,000 patients in this cohort, 1 year recurrence rate is pretty good, over 87% for proximal type AF and 78% for persistent AF success. However, as patient gets older, AF recurrence continues like this. I think the first AF recurrence 5 years after the de novo procedure might be AF progression. Although we can reduce the AF burden by catheter ablation, it is not possible to cure this degenerative disease. How long can we delay the ablation for this progressive disease? Although AF duration is an important prognostic factor, over 40% of AF is asymptomatic or minimally symptomatic. So in this study, we assume the AF duration based on the first documented ECG and evaluated rhythm outcome after catheter ablation. In paroxysmal AFib group, the AF duration did not affect the rhythm outcome at all. However, in persistent or long-standing persistent AFib lasting longer than 4 years showed a significantly worse rhythm outcome in this study. We previously analyzed 9-year trends of AF ablation in over 2,200 patients during the last 9 years. Procedure time and the empirical extrapulmonary vein ablation and overall decreased remarkably. And in spite of reduced extra PV ablation and procedure time, the overall recurrence rate is reduced significantly. I think Story AF2 published in 2015 and improved their ablation catheter efficiency affected this outcome. The overall complication rate of AF ablation did not change in the last 10 years. However, we are using more aggressive ablation protocols such as hyper short duration RF, but trying to reduce vascular complications by using vascular ultrasound or single transeptal sheaths. Now we are using NOAC in most of the patients who undergo AF catheter ablation except for valvular AFib. In this multi-center randomized clinical trial, we compared uninterrupted warfarin, single-dose skip schedule, and 24-hour skip NOAC protocols. There was no difference in bleeding or thromboembolic complications among NOAC skipping schedule, and there was no difference among 3 NOACs. So we are using a single-dose skip schedule for the AF catheter ablation nowadays. We know that AF ablation complication risk is higher in women, especially elderly ladies. And in this study, we measured the pulmonary vein intra-wall thickness of a CT scan and evaluated the sex difference in wall thickness and risk of complication. We found major complication rate and risk of cardiac tamponade are significantly higher the ladies older than 70 years old, and their left and right side intra-wall thickness were significantly thinner in those old ladies. Cornerstone is a standard score for malnutrition composed of albumin, cholesterol, and lymphocyte count. It is different from body mass index. And among over 3,000 patients who underwent AF ablation, 0.4% of patients had moderate to severe malnutrition. We found significantly higher overall and major complication risk in those patient group, especially in female patients with malnutrition. Therefore, we have to be very careful during the procedure for the patient with small body size, malnourished old ladies. We found that the AF ablation itself increased the left atrial pressure at the repeat procedures, especially in patients who underwent empirical extra PV LA ablation. And we measured the 1-year follow-up echo parameters instead of invasive LA pressure measurement in this study. And the stiff LA physiology was observed in 3.7% overall patients after AF ablation and was associated with diabetes, underlying diastolic dysfunction, and empirical left atrial extra PV ablations. During the last 10 years, we tried the various ablation lesion set to improve the rhythm outcome of catheter ablation. However, now we realize that the routine empirical extra PVLA ablation does not help the patient at all. In these 2 RCTs, we proved that CPVI, pulmonary vein isolation, is good enough for paroxysmal type atrial fibrillation ablation. What about in patients with persistent AFib? I believe Story AF2 proved provided a major turning point of a persistent AFib ablation strategy, including my lab, as Story AF2 or reaffirm failed to prove their benefit of linear, cafe, or rotor ablations. We became more obsessed to pulmonary vein isolation. However, about 40% of patients recurred within a year. What about the patient group was originally persistent AFib, but changed to paroxysmal type under antiarrhythmic drug or cardioversion? These 2 RCTs shows that the empirical linear ablation does not improve rhythm outcome in this patient group. And even after complete electric isolation of posterior box lesion, it doesn't change the outcome at all. What about the patient with long-standing persistent AFib? Although we found better rhythm outcome after electrical isolation of posterior box, we call it POBI in this retrospective registry study data. And the additional cafe ablation after Dallas linear lesion set did not improve rhythm outcome in patients with long-standing persistent AFib. We know that posterior inferior line has a risk of esophageal damage. Therefore, we achieved the POBI by touch-up ablation inside the left posterior wall after the lines in this multicenter randomized clinical trials. In this POBI trial, 73% of included patients were in long-standing persistent AFib state. There was no benefit of additional posterior box isolation in persistent AFib population. We just submitted another randomized clinical trial evaluating the value of POBI in the reduced second ablation procedure. Unfortunately, POBI still did not improve the rhythm outcome of a redo procedure. In the last 10 years, we also realized that not only are there more complications in women, but also rhythm outcome is worse than in men. The outcome of AF catheter ablation was worse in women, especially those younger than 60 years. And this poor outcome reflected higher cardiac parasympathetic nerve activity in women than in men after AF ablation. In this time, we proved the sex difference of rhythm outcome after redo procedure. And in Cox regression analysis, worse rhythm outcome of a redo procedure was independently associated with women, non-proximal atrial fibrillation, and extra PV triggers. So women and extra PV triggers are poor prognostic factor together after AF ablation. Now, I would like to mention the role of extra PV triggers. We learned it during the repeat ablations. Does the number of reconnective pulmonary vein potential affects the outcome of second procedure? The answer is yes. In this study, 37% of patients maintained the PV isolation at repeat procedure in spite of recurrence, and the outcome of the second procedure was worse in those patients without PV reconnection than those with PV reconnection. This outcome reflects the contribution of extrapulmonary vein foci as the mechanism of long-term recurrence. And we proved the reduced number of PV reconnection as later timing of recurrence after de novo procedure, and recurrence within a year, between 1 and 3 years, and after 3 years. And as recurrence timing was later, the proportion of extra PV trigger was lower at the de novo procedure. However, when those recurrent patients underwent rhythm mapping, the extra PV trigger was more commonly found in patients with later recurrence after 3 years. These findings suggest AF progression and extra PV triggers contribute to the delayed recurrence after 3 years of de novo ablations. In this study, we systematically reviewed the extra PV triggers at de novo and repeat procedures in over 2,000 patients with isoprotein provocation. And we found extra PV trigger is 12% of de novo and 29% of redo procedures. And the most common site of extra PV triggers were on the septum, coronary sinus, and SVC, not in posterior wall of LA or appendage. More importantly, over 30% of extra PV foci mapped at the redo procedure matched with previously done empirical ablation sites. 1/3 of extra PV trigger in redo procedure matched with previous ablation sites. As you expected, rhythm outcome was worse in patients with extra PV trigger in both de novo and repeat procedures. And it was even worse in patients with multiple extra PV triggers than those with single triggers. Are isoprotein provocation and extra PV trigger ablation valuable? The answer is yes. Professor Young Kim's group conducted a randomized clinical trial, and the rhythm outcome was better after extra PV trigger ablation. We also compared the isoprotein provocation and trigger ablation versus just finishing the case without isoprotein provocation. And provocation and ablation improved the rhythm outcome in this study. However, rhythm outcome was still worse in patients who showed the extra PV triggers in spite of additional ablation. We know the higher chance of extra PB trigger at the condition of acquired atrial structure remodeling. However, extra PB triggers also have a genetic background, and recently we found that the zinc-ping-Homebox gene, which is the top second AF-associated genome, has a significant relationship with extra PB triggers. And zinc-ping-Homebox gene has functions for inflammation, fibrosis, or matrix remodeling. Then, how can we improve the rhythm outcome of AF ablation in the future? We previously reported 35-watt endurance ablation is better than 25-watt electrical PV isolation, and mesh-type tip ablation catheter also improved the AF ablation outcome. However, currently we are using 60-watt hyper short duration RF ablation with flexibility catheter. When we compare the 60-watt hyper short duration with conventional 35-watt after propensity score matching, and rhythm outcome and complication rates did not differ. However, hyper short duration ablation significantly reduced their procedure time. Then, how different between hyper short duration versus cryoballoon ablation? In this CRAFT RCT, we found no difference in the rhythm outcome in patient with proximate AFib, but even shorter procedure time with cryoballoon ablation than hyper short duration ablation. However, the complication rate was marginally high in cryoablation because of 2% risk of a right frenulum paralysis. In the last 10 years, we failed to improve the rhythm outcome of a persistent AF ablation by changing the lesion set, hyper short duration RF, or cryo. Therefore, we tested the efficacy of computerized modeling guided AF ablation in their randomized clinical trial manner. This is protocol. At the beginning of the procedure, we acquired the voltage map after restoring sinus rhythm by cardioversion. Then we integrated clinical voltage map to AF modeling, induced the virtual AF, and then localized dominant frequency site. By improving the computation power, we can generate the dominant frequency map within 30 to 40 minutes during PB isolation procedure. And after the procedure, dominant frequency information is given to the operator for the additional DF ablation. Based on this protocol, we randomized 170 persistent AFib patients to modeling guided ablation group versus empirical ablation group. If I make a long story to be short, we conducted additional DF ablation after PB isolation in DF ablation group, and this group shows a significantly better rhythm outcome than in empirical ablation group. Another important issue might be the pre-selection of poor responders. Now we are using the AI, artificial intelligence algorithm, to pre-select the poor responders, and just started the prospective randomized clinical trial for decision-making for AF ablation candidates. The role of AI is to substitute useful invasive parameters with non-invasive clinical parameters to predict AF ablation outcome. So this is in conclusion, ladies and gentlemen, AF catheter ablation in heart failure is beneficial in heart failure control, stroke prevention, cognitive function, or renal function. AF is not a curable disease, but the long-term outcome of ablation has been improving. Women have higher risk of complication and recurrence after ablation. No more empirical extra PB LA ablation is justifiable. Non-PB triggers with genetic background might be their next target, and hyper short duration RF and the cryoballoon ablation reduce the procedure time remarkably. And the pre-selection of a poor responder is an important issue. Thank you very much for your attention, and I would like to express my gratitude to all my team, colleagues, and ex-fellows and collaborators. Thank you very much.